In the Nordic myeloma study group, as in the German, we have a lot of clinical trials in maintenance treatment, such as carfilzomib and high-dose treatment. We have the BITE study that to be started as a maintenance treatment in myeloma patients, both in elderly and young patients. I joined myself ASCO, and I was impressed by 3 presentations that I will share with you. And if I have time, I will tell you about some programs that we have at my site to deal with myeloma and myeloma relapse. So the first study that I want to share with you is a study on teclistamab that is started for 3 or 4 years ago with first in human design, where we increase the dose of every 3rd patient. And the study has been ongoing a while, and we start seeing some effect and side effects that I will share with you. Dr. Osama presented this study at ASCO, and I know it will be presented at EHA. So this is a bispecific antibody combining the BCMA and the CD3. The patients that were included were relapsed refractory patients with a median prior lines of 6. There were the majority were triple refractory to IMiDs, proteasome inhibitors, and anti-CD38, and there were about 50% of the patients were penta-refractory, as to say they are refractory to more than 5 regimes or known drugs in treatment of myeloma. The median age was 62, but there were about 20% of the patients over the age of 70. The response rate is improving with time because we are increasing the dosage as the design is, and the presentation was on the total dose of 270 microgram per kilo. The dosage today that we use intravenously is 720. So there is a lot of increase in dose. I'm not allowed to share with you the data on the 720 microgram. The important thing is the cytokine release syndrome that Herman Ensela shared with you is the dangerous side effect of the treatment. We don't see any grade 3 or 4 CRS with this study. As to say, we see mild symptoms of CRS. About every other patient develops CRS, but as I say, it's grade 1. That's mean some kind of fever, occasional fever, 2-3 hours, not more than that. The over response rate was, with this low dose, was about 70, exactly 67%. And surprisingly, more than 50% of these responses were more than VGPR. They are very, very good responses. So the conclusion is this product give a high response rate, very good responses, more than VGPRs. The CRS rate is about 50%. There were no grade 3 or 4 CRS, as to say, mild symptoms. And until today, in spite we are using the 720 microgram per kilo, there is no limiting toxicity. But we are reaching a higher response with the higher doses. That's the first study that I found very interesting to share with you. The other one is a huge study done by the ECOG group in the US. I know that in US, more and more centers are using carfilzomib to start with in first line. Our standard in Europe for treatment of both elderly and young patients is lenalidomide, bortezomib, and dex. This is a comparison between the two regime. RVD, standing for Revlimid or lenalidomide, bortezomib, dex, and KRD, standing for carfilzomib, Revlimid, and Dex. More than 1,000 patients were included, about 500 in each arm. The median age was 65, and more than 30% were above 70. Well-balanced study, and including high-risk patients. The thing is, when it was presented, the median progression-free survival was almost the same between the two arms. It was 34.4 for the BRD and 34.6 for the KRD. I myself was surprised, and that's why I'm sharing the results with you, because as myeloma doctor, we always thought that carfilzomib probably is give more responses, and it do actually. And when you look at the response rate, it is more with the KRD. But the most important thing for me as a doctor treating patients is the progression-free survival and the overall survival. So the author suggests that the VRD should be the backbone for treatment, and it should be probably combined with other drugs. As you probably know, the anti-CD38 is becoming the standard even in first line. So my conclusion from this study is we will still use the RVD, and we will introduce the anti-CD38 to first line. Another study that I found also very interesting, it was from Arkansas, from Little Rock. It's a retrospective trial. They choose patients that have done MRD analysis. Conditions that there are 2 confirming MRD analysis, and both are negative with at least 3 months in between. So it's a very well-defined population. They had more than 600 patients. And they follow these patients during a time with repeated MRD analysis, and so that when the patient lose the MRD negativity, then they will get shorter PFS. That, in my mind, will condition the follow-up of the patient with MRD during a longer time, because it is implementing the effect of losing it on PFS. So I haven't done that. I just check MRD the first 2 years in my patient, but looking at this specific study, I will probably start following up MRD during longer time. Starting treatment on MRD positivity, it's a question that we probably don't have a clear answer for, but knowing that the PFS will be shorter with the conversion from negative to positive state, I will most probably do that. These were the 3 studies that I want to share with you, and I will tell you some on the program running at my site, not within the Nordic myeloma group, but at Karolinska Institute. So as Professor Ansela shared with you the CAR-T program and the risk with the CAR-T, the CRS, we are also worried about that, and we are starting a program there where we collect peripheral blood from our patient, 1 unit. We separate NK cells and culture them during a period of three weeks. We give the casual treatment to our patients, the high dose treatment that include VRD. We do a high dose treatment, and as a maintenance, we give cure NK cells that we cultured from the patient 3 times with 1 week in between. We have run a phase 1 study with no major side effects, and we are planning now to do a phase 2 study where we randomized maintenance after high dose treatment with the NK cells plus anti-CD38 maintenance in 2 years, compared to only anti-CD38 as maintenance. This study has just been started, and I have no data to share with you. The other thing is that we are, when we are collecting these units of blood, we are sparing the T cells for probable future use in a relapse refractory situation. It's a very unique way to do it when you collect T cells and NK cells at diagnosis. You never know if you need to use them, and it's probably very costly to do at a higher scale. So I don't know if you will ever succeed with this idea. With the NK cells culture, we are going on with it with the phase 2 trial, but the T cells, I don't know actually. The other thing that we are trying to develop is to develop a CAR NK trials in combination with CD38 or the BCMA antibody.